What I'm going to do today is focus in on a very specific concept of right ventricular function, what happens during acute lung injury and its assessment, and the assessment of the heart. And I want to make an announcement beforehand that regrettably, I have to leave immediately after my lecture because I have to fly home to Pittsburgh because my daughter is getting married. And I'm not at all upset, thank you. I'm not at all upset because she's getting married. I am upset that I can't stay here with you, but as Massimo Antonelli says, it's a very good reason. Okay, so the only conflict of interest I have is that I'm a consultant for Edwards, and they use pulmonary artery catheters, and pulmonary catheters are part of the data I'm going to show, but that's about it. Okay. When we look at, and most of the data I'm going to show you is from our own group. And when you look at the right ventricle, here shown in a gated CT scan from the University of Pittsburgh published a few years ago, you can see that the right ventricle looks like an afterthought. Here you have your beautiful concentric, thick-walled left ventricular function. And then the right ventricle seems to be, by the way, it's really not the right ventricle, it's the anterior ventricle, but that's another story. You can see that it sits on the side here on the top, and when the right ventricle constricts, the left ventricle contracts, it literally hugs the right ventricle and makes the right ventricular systolic function occur. So 70% of all right ventricular developed pressure is due to the contraction of the left ventricle. Okay. So anyway, the problems between the two ventricles have been shown many times before, and the first one is the right ventricle can't take pressure. It fails. And this is just an study, but I could have picked any out of the literature. Guyton showed it years ago. And that is that if you increase mean pulmonary artery pressure from a baseline value, in you right now, your pulmonary artery pressure is about 12. Okay? If you have a patient, their pulmonary pressure is 15 to 20, it's already elevated. It goes up that high with exercise normally, but it doesn't normally. But if you take a normal ventricle, it'll fail when the pressure is 30. So if I put a PA catheter in a patient and they have a pulmonary pressure of 35, I can tell you they have chronic pulmonary hypertension because if I had increased it acutely, they would have simply already been dead. So the normal right ventricle cannot handle higher pressures at all, whereas the left ventricle, it lives for pressure. Its job in life is to maintain perfusion pressure of the organs, so it maintains pressure very well. In the assessment of right ventricular function, and Sheldon Magder, when he comes here, will be discussing this in greater detail. This is actually one of the most important uses of the central venous pressure. It has several uses as well. None of them are to determine your volume responsiveness, but it is an excellent parameter of cardiac function. If your CVP is elevated, you're sick. I don't know what it is, but everyone in this room has the same CVP value right now. And if we add every one of your CVP values up, it would equal the same as yours right now. It's 0. The normal central venous pressure of a human being sitting upright is 0 because there's no back pressure to venous return. We use pulmonary artery catheters far too little when we're assessing right ventricular function, but that's probably not going to change. In the cardiac cath lab, they're routinely used in every patient that they assess for right ventricular function. What we use in its place is echocardiography, and I'm going to talk about that a bit. I love echo. We've done a lot of work with it, but it is not continuous, but it is nice. It shows you a lot. And the simple assessment to know is if cardiac output increases with volume or exercise, you have no right heart failure. So if you're no longer volume responsive for fluids, you're in cor pulmonale. So think about that when you fluid resuscitate a patient until they're no longer volume responsive. So we can use all of them. Hunter Champion describes several examples in this review article in Circulation of how you can use echo, and one of the favorite ones is looking at the tissue Doppler movement of the tricuspid valve. The other thing you can look at is the velocity of tricuspid regurg to determine pulmonary artery systolic pressure, and of course you can see here that the real right heart catheterization pulmonary systolic pressure and the estimated value look pretty good, but that doesn't work for individual people because I can have a Doppler pressure that says it's 45, but my real pressure is either 35 or 70. I think those are pretty different. Or I can have a right heart cath pressure that I know is 35, but the Doppler is 35 to 70. So individual patients, you're not going to be accurate. All you'll be able to know from echo is that the pressure is elevated. So I want to do a little bit of basic physiology first, and I'll go through this quickly. We don't understand how the right ventricle works, or we didn't, until we started looking at it. We just assumed it was like the left. Is there any relationship between right ventricular end diastolic pressure and volume? Well, with Charles Rieu's in Brussels, we looked at a whole bunch of patients that came in the emergency department. We measured right ventricular end diastolic volume and right atrial pressure with fluid resuscitation, and we found that there was no relationship. Well, you'd say, well, that's different diastolic compliances. Why don't you show me the change in pressure to the change in volume? Okay, here it is. There's still no relationship. But it's just a single point in time. Why don't you show me a patient that you fluid resuscitate and take it out? I bet there's a relationship there. Well, with Jean-Francois Deneau in septic patients, there's no relationship between end diastolic volume and right atrial pressure. See, in some patients it goes down. I'm not measuring transmural pressure. Remember, you're supposed to measure pericardial pressure? Okay. So with Jean-Louis Vincent, we measured pericardial pressure in human beings as we went up and down on PEEP. There's no relationship between right atrial transmural pressure and volume. Well, does it matter? Isn't just right ventricular end diastolic volume preload? No, because as you increase the right ventricular volume significantly, there's very little change in stroke volume in a person who isn't in shock. And this is true whether you're looking at septic shock or PEEP. Why is this the case? It's the case because under normal conditions, the volume in the ventricle increases and decreases below its unstressed volume, just like the volume between my fingers is changing, but I'm not stretching my fingers at all. They're the same length. And in fact, this was described nicely in human beings by Tyberg in 1986. He put a pericardial balloon in human beings right on the heart before starting cardiac surgery, and he fluid resuscitated them. And he measured the relationship between the change in right atrial pressure and the change in pericardial pressure, and they're absolutely linear. So when you give fluid and right atrial pressure goes up, it's because pericardial pressure went up. There's no change in the descending pressure of the right ventricle. So we looked at this for the very first time ever back in 1992 using a conductance catheter. This is the first time anyone had ever measured continuous volumes. What you see here is that when you look at the right ventricular filling, it's actually a very flat curve. And indeed, one of our better studies is shown here. Look at diastolic compliance. As the ventricle is filling, its pressure is actually falling because it has nothing to do with distension. It's just relaxing more and it's filling up. What you consider diastolic compliance is the end diastolic points of individual curves. What we've done is an inferior vena cava occlusion, and so we get progressively decreasing end diastolic volumes. So for any given contraction, the heart goes up like this and relaxes down and comes back. So what you think of as diastolic compliance is really the pericardium limiting filling. And if that's the case, as I increase end diastolic volume, if the preload's constant, ejection fraction should fall. And everyone who's ever measured ejection fraction for the right ventricle has shown that as the increased end diastolic volume, ejection fraction goes down. And that's true of ARDS, it's true of septic shock, whereas if you've looked at left ventricular ejection fraction, it goes up with increases in volume, right? It's one of your preload parameters. It's because they're doing different things. So when it comes to looking at the right ventricle and preload, right ventricular volume changes normally in you or I over a physiologic range not associated with changes in wall stress. So preload is constant. But is preload independent of volume? No. If you have right ventricular overdistension or right ventricular hypertrophy, then preload and volume become linked. How about looking at right ventricular end systolic function? Remember the end systolic elastance or stiffness of the ventricle, which is the end systolic pressure-volume relationship of the left ventricle, is contractility. Well, you can see the same thing for the right ventricle, too. This is that same picture you saw. But the problem is you have systolic ventricular interdependence. In this study, which we did years ago, all we did is we increased right ventricular pressure by putting a snare on, on the left ventricular pressure by putting a snare on the aorta. So you can see here under continuous beats, there's a marked increase in arterial pressure from about, 90 to 180. Look what happens to right ventricular systolic function. As you make the left ventricle pump harder, it squeezes on the right, and look at what happens. Okay? This is just a prettier picture of the same thing. So most of right ventricular systolic pump function comes from left ventricular ejection. This is the reason why the right ventricles often get better if you give them dobutamine, because it's made your left ventricle good. What about happens when you give the volume of the ventricle too much? These are CTs of a normal person and a person with right heart failure, and you can see here that what you've done is you've squeezed in on the left ventricle and it has no preload. If you make the ventricle, of right ventricle bigger and bigger, left ventricular diastolic compliance becomes less and less because the pericardium limits the absolute biventricular volume. If I've got a big fat man and a little skinny man inside of a corset and the big fat man takes in a breath, the little skinny man gets squeezed. And this is the left ventricle getting squeezed. And this is shown in the study in which we increased right ventricular function here. And you can see when we grossly dilated the right ventricle, the left ventricular systolic function fell. And this is the reason why with a massive pulmonary embolus, you die immediately. Because the increase in right systolic pressure to 35 or so causes the right ventricle to dilate. The left ventricle has no volume. Arterial pressure falls. You're not perfusing the coronaries. Your right atrial pressure is too high for venous return, and you're dead. So the cause of low output is right heart failure. A myocardial infarction, on the other hand, usually causes cardiac output to go up and the pressure to rise from the increase in catecholamines. So left ventricular failure is not usually associated acutely with falls in cardiac output, only right ventricular failure. And this is just a beautiful picture from Francois Jardin. I don't know if he took it or if Antoine Villard-Baron, but Francois gave it to me. And you can see here that if you volume load a person, they develop cor pulmonale with paradoxical septal shift. So right ventricular ejection efficiency is uncoupled in diastolic volume except with overdistension of the ventricle or ischemia. Well, let's go through this a little bit further. This is data from our institution in which we did echo, we did speckled strain. So what I'm actually showing you here is the strain relationship of the right ventricle under normal function. This is a long axis, long axis view. And you can see here's the interventricular septum. Here's the left ventricle doing what it's supposed to do. And you can see that the strain in the right ventricle is homogeneous across all these segments. This is what happens with pulmonary hypertension. Notice the paradoxical septal shift. The strain is significantly less in areas. And when you get into global heart failure, it's pretty ugly. This is a human being. Published this a few years ago. And these strain effects can be induced by simply volume resuscitating them. We can assess this further by looking at when the right ventricle contracts, it has to contract against a pulmonary artery pressure, which is normally really low. But if the pulmonary pressures are high because of ARDS-induced increased pulmonary vascular resistance, as we described yesterday in the opening session, from the hypoxic vasoconstriction and vasospasm associated with acute lung injury, the arterial stiffness, the arterial elastance, EA, can go up. So in collaboration with Robert Naye and his PhD student Vanderpool, who came to Pittsburgh with us for a year, we looked at the arterial elastance of patients with hypertension and determined their survival rate. And as you can see, when they had hypertension, all the things like 6-minute walk test, pulmonary vascular resistance, right ventricular stroke work, none of those things predicted mortality. What predicted mortality was an excessive arterial elastance to the ability of the right ventricle to contract, its own end-systolic elastance. And Antoine Villard-Baron showed that before. When he looked at patients who had, and I presume he'll show you that data in his lecture, when he looked at patients who had acute cor pulmonale, he used an echo Doppler to assess pulmonary input impedance as the waveform analysis of pressure to flow. And he showed that it was the increase in impedance that was causing the heart failure. Okay, so based on all of this, I'm going to give you some overly simplistic rules, but they are founded on the physiology and the clinical data, which I've described. The first is that with exercise or volume loading, right atrial pressure must increase slightly. The heart has to dilate up, the right ventricle has to get bigger for cardiac output to go up, or cardiac output cannot go up from a volume perspective. But if the ejection fraction also falls and stroke volume doesn't change, that's acute cor pulmonale. Another way to say it is if you give volume and the CVP goes up by 3 millimeters of mercury, stop. You're in acute cor pulmonale. For cardiac output to increase, right ventricular end-systolic volume must increase because right ventricular end-diastolic volume and end-systolic volume are absolutely linked because there is no preload. And therefore, because of that, and this is important, since you have a pericardium, there is an absolute limit, and it's quite minimal, on how much you can increase your patient's cardiac output just by giving volume alone. Because you can only do it by increasing end-diastolic volume of the right ventricle, and you only have so much volume in there. So there's a limit to how much fluid resuscitation can increase cardiac output. The primary treatment for right heart failure is to maintain coronary perfusion, which is either to decrease pulmonary artery pressures, which is good, if you can, or maintain arterial pressure greater than pulmonary pressure to maintain coronary flow. And so the rescue for acute pulmonary embolism is epinephrine or norepinephrine to increase arterial pressure so that you can maintain coronary perfusion. So in conclusion, pulmonary hypertension-induced right ventricular dysfunction commonly occurs about a third of patients with ARDS. Protective lung ventilation has been able to markedly minimize the amount of acute cor pulmonale because of the prevention of this overdistension and maybe also less lung injury. Echo measures of right ventricular function are very sensitive, and everyone in this room should be trained in echo. If you're not, please learn it. It's an essential part of what we do at the bedside every day. It shouldn't be something you call someone in to do. It should be like a stethoscope, something that you pull out exactly when you need it. If your volume in the ventricle rises quickly with fluid resuscitation, stop and reassess. Make sure they're not going into cor pulmonale. And finally, if you fluid resuscitate a person until they're no longer volume responsive, you just put them in acute cor pulmonale. And is that really a place you want your patient to be? Wouldn't you rather have them in a spot where they will be volume responsive and can handle the stresses? And with that, my future son, I'm going to show you this. This is my grants, and these are the people at the University of Pittsburgh that I worked with. And these are the people in Brussels. And my future son-in-law and my daughter, thank you.